It's really prevalent. It does cause serious disease, and in fact, NAFLD is now the #1 indication for liver transplantation in the US, and I don't think Europe is far behind. Now, essentially, that Hep C is curable. And I think it is important that we, as liver specialists, as general pediatricians, really do know about this disease, pick it up early, and try and manipulate management to suit the individual child. So I'll stop banging on about how enthusiastic I am about this area now and just go into a little bit of background. So the Lancet commission in liver disease. So you will know possibly that the Lancet editor is a hepatologist, or was a hepatologist, and recently in the UK, well, not recently, actually probably more a decade ago now, a czar of liver disease was commissioned, and that is largely due to the recognition that actually, although all of, not all, but most of the other kind of organ systems, particularly in adults, causing death and disease, really, plateaued or improved over the last few decades. So this is because, heaps of money was piled into stroke, to, ischemic heart disease, into cancer. And we all know that from, the amount of fundraising in the charitable sector, but plus all the different schemes that the NHS has really plumbed money into. But liver disease in isolation has really taken off in terms of the standardized mortality rate. And a lot of this here, so I guess in the 80s, 90s, was to do with Hep C. But now that we really do have a cure for Hep C, so, sustained viral response for, forever, essentially, with the new agents, and NAFLD has taken over. And it's a really important consideration in adults, but it's also a really important consideration in children, because Ludwig, who described the disease in 1980 in adults who had a disease in their livers similar to that seen in alcoholics, was then followed very closely by Moran three years later, who described the same disease in children. So the definition of NAFLD is essentially steatosis, so fat in the liver, with or without inflammation and fibrosis, in the absence of any other known inherited metabolic defect or toxins, i.e. alcohol, and associated in the majority with obesity, overweight, and insulin resistance. And this foie gras, I guess, appearance was up until about 10 years ago, was thought to be reasonably benign condition. So simple steatosis, no inflammation or fibrosis, and it's just a bit of fat in the liver. But we know that it is really nigh on impossible to tell apart those who have simple steatosis in their liver and will remain with simple steatosis from those who go on to develop a real disease. So NASH, steatohepatitis, and even more recently recognized steatofibrosis. So what matters in liver disease is the fibrosis. Okay, so I think, acute liver failure aside, chronic liver disease, what matters is fibrosis, is the amount of scarring in that liver. Liver inflammation, to me, doesn't matter so much, because it really is a point in time. So that people's ASTs, ALTs go up and down a lot. But fibrosis is fixed. And I'm not saying fibrosis isn't reversible. It is up until the point of cirrhosis. But the recognition now that you don't actually have to have abnormal ALT, AST, or any evidence of inflammation in your liver to have a proper disease. So the prevalence of NAFLD has risen dramatically over the last 2 decades in both adults and children, and it's no surprise to anyone that this closely follows the trajectory of obesity. And I guess the prevalence of NAFLD is highest in those countries with the highest prevalence of obesity. And I guess the caveat to that is the is the ethnic predisposition that we'll talk about. But essentially, NAFLD prevalence follows this map. And there's been a number of very useful cohort studies or epidemiological population-based studies looking at the prevalence of NAFLD in children. And probably the most comprehensive study is this one by Schwimmer. And they looked at post-mortems of children who died from accidental injury in California, and albeit that was what good 15, 16 years ago now. So these children had no other medical conditions, and they found that in 9% of all comers between the age of 3 and 18, 9% had some degree of steatosis. So yes, this is California, but it wasn't necessarily a very obese population. It was children, as I say, who died in road traffic accidents or other accidents. And in 3% of that cohort, they found significant inflammation and fibrosis. And that, again, you've got probably a higher Hispanic population there who are more susceptible to NAFLD, but that has kind of been the gold standard in terms of now what we look at for prevalence. We thought that because the feeling worldwide was that the obesity epidemic in children was kind of plateauing, that the NAFLD would follow that. But actually, a more recent study from last year by the same group has showed that that's not the case at all. And the prevalence, the incidence rather, of NAFLD continues to increase. Maybe that's because we're better at picking it up, but and maybe that's because we're better at screening, as with this study. So this study was done in children with obesity. But it still stands, I think, that NAFLD is an important condition in 2021, and we need to take it seriously in children. But NAFLD for me is about much more than, you know, obesity, fast food. And there are unique characteristics in a pediatric population that we need to consider when we're looking at this disease. So the first is the genetic and epigenetic factors, which I want to discuss because not that it's terribly useful when you've got a patient in front of you, but just my whole thinking about NAFLD kind of stems from, you know, how I see the pathophysiology of it. So looking at, you know, at our understanding of this disease too, we have to look back to the intrauterine environment and early infancy, including breastfeeding. Children are different because the maturing liver is vulnerable to toxins, is more vulnerable to toxins. And actually, there's really nice studies in zonation looking at the different parts of the liver and how that matures over time, and why, you know, I mean, pharmacology in children is different to that in adults, and how the liver deals with different stresses and you know, it has different detoxification functions, if you like. And obviously children are undergoing periods of rapid growth, including puberty. And again, that insulin peak just prior to puberty really does have an influence on what their liver looks like in the context of kind of insulin resistance. And I get the bottom line here that I know that we find significant, i.e. bridging fibrosis. So fibrosis is scored from F0 to F4 in certain, you know, using certain methodologies. And F0 is no fibrosis, F4 is cirrhosis. Bridging fibrosis is F3. And when we do liver biopsies in NAFLD, and we do them less and less nowadays because there are another non-invasive methods of talking or thinking about fibrosis, we find significant bridging fibrosis in 40 to 50%. And that is really scary, considering that child probably has another 60 or 70 years to live. And unless we reverse the underlying mechanism of disease and the pathophysiology of that disease, they are likely to progress onto cirrhosis, decompensated liver disease, and even hepatocellular carcinoma. So I just wanted to talk about pediatric NAFLD and just differentiate it a little bit from the adult disease. I wanted to talk about it as a disease model and how to think about targeting intervention. And then looking at the treatment and longitudinal monitoring of pediatric NAFLD. And as I say, a lot of this may not be very practical knowledge, but it's just, I just want to explain why I'm so interested in this condition. And I guess a lot of it can be extrapolated out to different parts of pediatric hepatology. So children with NAFLD will often come to you incidentally, and they'll maybe have non-specific symptoms like abdominal pain or fatigue, and often have a family history of the metabolic syndrome, and will have an incidental liver number check or ultrasound scan which shows fatty liver and or raised transaminases. The majority, it has to be said, will be overweight or obese. And in our cohort in King's, you know, roughly 3/4 were obese, but there were a substantial proportion who were certainly in the Z score for overweight rather than obese. And then an even smaller number, but a significant number, who have what we call lean NAFLD. So these were in the normal BMI Z score range. Have to say that the majority of those, I mean, we do a big comprehensive workup to make sure we're not missing any other problems, but will have visceral obesity, so this central adiposity. And there are really good centile charts for abdominal circumference. And actually, when I'm treating these children, I don't so much rely on what their weight is, but more what their abdominal circumference is. And I think that probably, and we know from different algorithms, that's really important in determining regression or improvement in steatosis itself. Many will have hepatomegaly or splenomegaly, 40% actually of our group is splenomegaly, and that always worries us because it implies a degree of portal hypertension. But remember that obesity is also an inflammatory state, so you may get splenomegaly as part of that. But again, it's very, very difficult to differentiate a spleen that's big because of liver disease or a spleen that's big because of inflammation. Remember to look for evidence of acanthosis nigricans, insulin resistance, and the cutaneous marker of insulin resistance, and in the nape of the neck, and axilla, etc. Really important to remember that transaminases may be normal, so that doesn't mean that they don't have fibrosis. Majority of the children that we would see have insulin resistance, and we would define that using either HOMI-OR, which is fasting glucose insulin of 22.5, or a fasting insulin rough measure about over 15. Almost a fifth of ours will have had impaired glucose tolerance, again on OGTT, and I would always measure the HbA1c in these children, and if it was over in old money 5.9, go on to do an OGTT in them. And then the ones with glucose intolerance, I've managed those with with the help of the endocrinologists. But to be fair, just to mention that I would, I've often, again with the blessing of the endocrinologist, started metformin in children who have good going insulin resistance without necessarily impaired glucose tolerance. And the nice thing about that is that you can start metformin for a year or 2 years, and then if that really helps them get rid of the weight, you see a regression in steatosis, then you can actually repeat their OGTT and often take them off it. So just to mention here that, the prevalence of obesity is such that although NAFLD is probably is the most common condition that we see in liver clinic, but B in children who are obese, other things can happen too. And just because you're obese doesn't mean you can't have something like Wilson's disease or autoimmune. So you've got to keep thinking, is this NAFLD? Because unfortunately, NAFLD is a diagnosis of exclusion. Rob Hegarty wrote a nice paper in JHEP a couple of years ago, looking at all the kind of the differentials of children with a steatotic liver, and I'm basing steatosis really as a diagnosis on ultrasound scan. So as abnormal transaminases themselves don't really mean much. Yes, you do have to see why they're abnormal, but for me, the kind of the barn door diagnosis of a fatty liver is made on ultrasound. So remember, ultrasound can tell you if you've got 30% or more steatosis. I kind of think if you've got less than 30% steatosis on ultrasound, it probably doesn't matter, and you're probably not at the threshold that you need much in terms of investigation. So I really do rely on ultrasound as a practical measure. MRI will tell you down to 5% steatosis, but that's not practical in any shape or form. So this particular article is written really, I guess, more from a hepatology, special interest perspective. And I guess from my practical perspective, what do I do for children who come to me with a fatty liver on ultrasound, or a bright liver on ultrasound, if you like. So remember, just as I'm talking, a bright liver on ultrasound can also mean hepatitis, so you do have to put the transaminases and the ultrasound together. But if you've got an overweight child who has a bit of tummy pain, had an ultrasound scan, a bright liver on ultrasound, spleen at the upper limit of normal, transaminases maybe 1.5–2 times normal, probably NAFLD. but you've absolutely got to outrule every other cause. Now, at this point, and I guess, you know, liver services have largely been centralised to King's, Birmingham and Leeds, and we would have always asked you, and we still do ask you, you know, to give us a shout if you're, you know, if you're worried about a steatotic liver or raised transaminases, etc. And we can guide the investigation and likely see, such as is the degree of centralisation now, which I think is all very appropriate. But it's nice too to have a bit of a handle on what's going on before any referral. And, you know, my very standard first line is what I would always ask on the phone. So LFTs, including a gamma GT, which you don't routinely do in Crumlin, unfortunately, but, you know, I'll always see the gamma GT box, because I do think it, you know, if your transaminases are normal, your gamma GT might not be. It doesn't mean an awful lot about the degree of fibrosis, but I think it's important to include in the liver screen. We'll always, with any liver test, the clotting, the iron ore is central, as you know. Lipids, fasting lipids ideally, and HbA1c are important as part of that obesity screen. Where I am working now, alpha-1 antitrypsin is really prevalent. I never look at the level, to be honest, because you can be really caught with that level. It's kind of an inverse inflammatory marker. So I always ask for the phenotype, and people are, you know, very obliging with that usually. Just have to find your local centre that does the phenotype, because alpha-1 can absolutely present with both mildly raised transaminases and a fatty liver. Again, where I'm working, celiac is very prevalent. We always do a celiac screen and an IgA. Thyroid function. I'd always send a ceruloplasmin. Whether or not I do a 24-hour urinary copper test pre and post penicillamine, this is all for Wilson's, is another question, because it is a bit of a nightmare, you know, to try and get it done properly. So, but a ceruloplasmin is a good first screen. If it's less than 0.2, then I would always ask for 24-hour pre and post. You know what? As I say, you know, ultrasound doesn't, you know, tells you about a bright liver. So it's really important not to miss something like an autoimmune hepatitis. So IgG and autoantibodies, so ANA, SNA, LKM, and Hep A, B, and C are the very standard tests that I would send initially. Now, I think I would certainly refer at this point, but, you know, the other things that we would look at in clinic in liver is, you know, LALD, so lysosomal acid lipase deficiency, you know, a blood spot came into very frequent use, mainly because the company was pushing enzyme replacement for this condition. Now, it can you know, look like NAFLD. This is a condition where you can develop a fatty liver and ongoing fibrosis cirrhosis. But, you know, to be honest with you, in the hundreds of kids that I've tested for this, I've not found one. So I think it's an important and relatively easy thing to do once the blood spot is around. Glycogen storage, transferrin enzymes, you know, ammonia in case of something like a urea cycle defect, so you're a metabolic a bile acid transport metabolism defect, and then also always think of CF. You know, and obviously the other things like PN on medication will be evident on history. So as I say, the diagnosis really of NAFLD is one of exclusion, and it's, you know, these kids we worry about. We, you know, a case presentation recently of a 16-year-old overweight child or overweight young woman who had a low ceruloplasmin, normal urinary copper though, and a normal, I ended up biopsying her, she's a normal tissue copper, which is really the diagnosis for, or the old-fashioned diagnosis for Wilson's disease. So I ended up calling her NAFLD for a year or two until her sister presented with Wilson's disease. And then we went back and looked at her genetics. We'd actually done, you know, a 75% cover for Wilson's genetics in her, but you know, that was about 10 years ago, and then put it through again the more up-to-date genes, and you know, she had Wilson's too. So you can, you know, you need to go back and back and back and think about this, particularly if you've got one test that's not fitting the whole picture. So just in terms of the histology, so, you know, you're talking mainly about macrovesicular steatosis. You remember this. This is big globs of fat in those hepatocytes. The disease in adults particularly is centered around the central vein. Okay, so it's a much more central. So you remember your lobules in the liver, and it's much more of a central disease. Whereas in children, it is much more of a periportal disease. So it's outside at the portal tract. And possibly this is to do again with the maturing of the functions of the liver and what's important in a child's versus an adult liver. And the relevance of this is that we know from big studies, particularly with the clinical research in the States, is that the children type disease, which is called type 2 NAFLD, is associated much more frequently with progressive fibrosis. So this is a more serious disease, if you like. And again, I'm just showing you this, not because I think it's very relevant to day-to-day management of these children, just because, you know, what do we see? Well, we see when we biopsy these kids, and essentially now in the last probably 5 years, we've biopsied much less, and I'll tell you why now. We would see that really in the biopsies that we do, there's not a huge amount of inflammation. And remember, these kids, in order to get a biopsy, need to have decent transaminases, and they, like, as in, you know, probably more than 2 to 3 times the upper limit of normal, and they need to have a big spleen. So they should be inflammatory, but they're not really on biopsy. But we see quite a significant proportion of fibrosis in these children. Now, obviously they're selected out, but my point is really that this is quite a silent disease, and it's only really with biopsy that you can tell the degree of fibrosis there. And the point here is that, you know, children with fibrosis already in their liver are kind of destined, unless something changes, to progress. Once you reach F4, it's still reversible, but then a certain number will go on to decompensate and really, you know, end up with liver transplantation or really significant end-stage liver disease. So just to move on then, I said I'd talk a little bit about genetics, more for interest than anything else, a bit about antenatal priming, a bit about, you know, children are a little bit different, not that much different, but is there anything different about a child's diet that might make them susceptible or make their disease more significant? But I guess the bottom line is that, you know, the disease that we see at presentation, even though this is a selected out cohort, is significant. So it's important not, you know, I think it is important to call this a disease rather than, you know, just a bit of fat in the liver. So there's been a number of genome-wide studies done in NAFLD, and obviously it's quite a prevalent condition, so it's easy enough to do. And the one gene that really is pulled out is PNPLA3, which is to do with triglyceride packaging. There are a number of others, and then if you look at the pediatric GWAS, PNPLA3, GCKR, and TMF6SF2, which are all involved in different pathways, but essentially all about, you know, the packaging and storing of fat in the liver. And, you know, the way that I conceptualize it is you've value for some reason you're genetically susceptible to gather fat droplets in your liver. In some people, but not in others, and the some people is mediated by genetic differences, I'm pretty convinced. In some people, those fatty droplets set up a kind of a splinter response. So they induce inflammation, and the inflammation then, to whatever degree, induces fibrosis. But you are genetically primed to develop significant disease in some, you know, or you're not. And differentiating those people out is really, really difficult. The prevalence of disease is such is that you can't, you know, it is an impossible task to really even screen or manage everyone with fatty liver individually. And we're not there yet in terms of the genetics, but I'm hopeful that if we can really define better the profile of risk using genetics, then we'll be able to select out those that we can really intensely manage and hopefully prevent significant disease. We know that if you've got more than one genetic variant, so these are quite common SNPs, so they're between sort of 11 and 24% in the population, then you are more likely to have, or, you know, NAFLD or more progressive fibrosis in the context of NAFLD. And we know too that particularly children who well, you know, this was a rodent study, but those with PNPLA3, this particular variant, which is the susceptibility variant in NAFLD, if you feed these individuals with a high sucrose diet, they develop higher levels of fat in the liver. Okay, so, you know, That's kind of obvious from what we know about the function of PNPLA3, but I guess it's just to prove the point. And what in terms of antenatal priming? So, even going back to the Barker hypothesis, we know that, even preconception, the preconception health of the mother, in addition to pregnancy health, really are kind of the first hits for the fetus, and that's not to to place too much emphasis on it, but we know too that a low and high birth weight, again in part mediated by preconception and pregnancy health, are certainly risk factors for developing A, disease in terms of NAFLD, but B, more advanced disease. And we know too that gestational diabetes is a risk factor for steatosis in the newborn. And steatosis in the newborn is probably pathophysiologically quite different to NAFLD later on. But we know from other studies that babies, who have, from a research perspective, been MRI'd and were found to have fat in their liver, are more likely to go on then. Usually they lose it, or we think that they lose it in early childhood, but then and this is backed up again by animal studies, more susceptible to developing NAFLD. So what about dietary intake and anything different in children? Well, certainly in the States, high fructose corn syrup is ubiquitous and really targeted towards children. And there's Mike Goran, who edits Pediatric Obesity, the journal, is a absolutely huge believer in fructose as this is the problem for NAFLD, and I don't think he thinks that that's the whole problem, and I think it's probably more a problem in the US than it is this side of the Atlantic, but even still, the first thing we will always do with children with NAFLD, and I'm sure it's the same with children obesity in general obesity clinics, is we'll get rid of the fizzy drinks. Because there's no doubt that fructose, and you've seen that with the rodent study in PLA3, will just induce fat in the liver. We did our own case control study looking at simple obese without NAFLD versus those with NAFLD. Really couldn't come up with anything very significant in terms of difference in diet. So my personal opinion is I don't think it matters. I think it's all about the genes and your underlying susceptibilities, and then if your diet does not suit you as a person, then you are likely to develop NAFLD. We know from the literature that increased fructose, absolutely, if you listen to Mike Goran, increased carbohydrate and short chain fatty acids, but really bottom line is it's probably just the total energy intake irrespective of source. So what does it all mean if you get an 8-year-old with kind of a very fatty liver and F2, F3 fibrosis? What does that mean going forward? So the longitudinal studies in kids aren't great. It's a slippery one, as you can imagine, to try and forward plan to really look at these children long term. So what we have, I guess, is mostly kind of retrospective stuff. Repeating biopsies in children is also an absolute nightmare, so it just doesn't factor, unless in the context of a clinical trial. But we know from adult studies, and again, a lot of these data are derived from kind of the NASH research network in the States, that actually to progress one fibrosis stage, we think takes up to about 7 years. Now, to be honest with you, I'd say that, I think that there is evidence there that children progress even more rapidly. But the honest answer is I don't know. And again, the key here is differentiating those out with a fatty liver, which is no harm to anybody, versus those who are going to want to progress. And no one can do that as of yet. I think in terms of the pediatric literature, we're really just looking at kind of case reports in those transplanted for NAFLD. And you do worry that because we don't see cirrhosis very frequently secondary to NAFLD in a pediatric cohort, that some of these diagnoses may be wrong. But what I know from my adult colleagues, both here and in the UK, is that actually, NAFLD now in the 20s and 30s, is becoming more and more prevalent as an indication for transplantation. And I think, we owe it to these kids, if we do diagnose them early, to do our very best to modify the course of that disease, because it is modifiable, and I guess that's the bottom line. So what about screening and follow-up? So, I mean, the recommendations are very mixed. So the North American Society there at the top recommends, screening all obese children, in that prepubertal state, if they have another risk factor, and they use LFTs to screen, which I don't think is really great, but it is cheap and cheerful. ASLD, which is the adult and ped, big association for liver disease in the States. There's no evidence. I mean, they're very honest about it. What's the point in screening people with obesity if we don't have a cast iron way of picking out those who are going to develop bad disease and of treating them? And then the UK, I mean, there was a nice document about 3 years now, who recommended testing those children and adults with type 2 diabetes and metabolic syndrome every 3 years, using this ELF score. So this is the Enhanced Liver Fibrosis Score, which is a composite of 3 pro-collagen biomarkers, which honestly I have a huge problem with, because ELF score was developed and validated in adults. I have not seen any, there's one paper, but I've not seen any very reliable, repeatable, useful data in children. And I think that the point here is completely missed. I think using something that measures turnover of tissue in a growing child is not an appropriate use, or it's not appropriate way to screen someone for chronic liver disease. So I think I don't use ELF. I do recommend to people who are looking at who are managing children with obesity to look at their LFTs, more to the point to get an ultrasound scan. But I have to hold my hand up and say, I don't have, aside from biopsy, I don't have a reliable method to be able to differentiate children who are likely to progress from those who aren't. And so we end up with a big NAFLD clinic, which is no harm. So just to mention again, some imaging techniques. So as I say, AST, ALT, just barn door. I mean, they won't tell you the whole picture, but they're useful. So ultrasound scan, very, again, probably the most I think the most cost-effective way. It's not the cheapest way, but it is the way to tell whether somebody has a decently fatty liver or not. The spleen size I use as proxy for, as I say, fibrosis, but the caveat that actually inflammation can throw you there. Transient elastography is something that we're using more and more. So the FibroScan, I don't know if any of you have had a FibroScan. So it's a really non-invasive technique using a vibration, pulse, and ultrasound technology to give you a score in kilopascal, so you can tell the stiffness of the liver. It's not bad. It's quite user dependent. There's a learner curve. It's a bedside test. Anybody can do it. Now we have a controlled attenuation parameter with the stiffness measurement, and this will tell us about the fatty content, which I think is really useful, not so much from a clinician's perspective, but really from a patient's perspective. If I can tell you that you've decreased your fat content of your liver by 25% by losing 3 kilos of weight, fantastic, and that really gives you the motivation to continue. There's other kind of fancier shear wave techniques which are based on ultrasound, and the problem with these is that they again kind of take more time from the ultrasonographer, and you need a fancy machine, and they're not as bedside, they're not as controllable by the clinician, but they're useful. And then really, and this is more from a research perspective, MRI techniques, and multiparametric MRI, particularly where you've got either elastography where you tell about stiffness, and PDFF, which tells you about fat. I mean, and they're beautiful pictures, but an MRI is not a practical way to screen anyone. And then I'm just going to finish, I guess, with a little bit of talk about NAFLD as a disease model and how you target the interventions. And I think conceptually with NAFLD, you've got your obesity, your insulin resistance, your free fatty acid supply, your accumulation then of fatty droplets, contributing, dyslipidemia, your pro-inflammatory pathways, which are largely, I guess, determined, I think, probably genetically, epigenetically. The bile acid and the gut-liver axis story, which we're not really going to have time to think about today, but they really feed into these pathways. Some oxidative stress as well. Again, you're genetically primed, I think, for this or not. So genetic susceptibility, obviously, from a treatment perspective, you can't do anything about it, but you can identify those who might benefit from one, treatment pathway versus the other. Insulin resistance, oxidative stress, they're both areas that clinical trials have kind of centered on. Dysbiosis, this is really topical, as you know, so the microbiome, there've been not plenty, but several trials of probiotics in children and in adults with varying results. And problem with clinical trials in NAFLD is, how long do you really need to see a difference? If you're talking about getting rid of fat in the liver, you probably don't need that long. But if you're talking about fibrosis regression or prevention of fibrosis and progression, you need years. So obviously it's difficult to design a trial that really shows what's what. And the whole field of bile acids, then, again, we're not going to have time to get into, but this, the relationship of bile acids, which as are kind of end result of kind of cholesterol metabolism, and their interaction with the gut microbiome is really now a topical area of interest in NAFLD. But I guess the point is that this is serious money, okay? So NAFLD is so prevalent that the pharma industry has exploded in it, and it is really, the number of clinical trials are just growing year on year, and we bat away offers to kind of be part of different pediatric investigation plans in this cohort. But I guess my whole point is that diet and lifestyle, which are notoriously the most difficult thing to change and achieve, are actually the most effective way of reversing the disease. And we know this is a really nice meta-analysis. In fairness, is in adults, but the pediatric data support it. If you lose 5% of your body weight, you'll resolve your NASH, your inflammation, in 10%. 35% will improve your steatosis. Most patients will achieve that. But if you lose 10% of body weight or more, you'll pretty much resolve your NASH, your inflammation, and your steatosis in pretty much everyone. And in 4/5 you will also improve to nearly normal your fibrosis stage. The really sad figure is that only 10% will ever achieve that. And I think this is the crucial point here. So this column here is the crucial point. Why? In the best clinical trials, in the clinical trials of the best drugs used to treat NAFLD, you will get usually 30 to 40% regression of steatosis and or NASH. Very few trials have looked at fibrosis, to be fair, because it's much more long term. But in the placebo group, you're talking about 20%. Because obviously these patients will be, very, very closely managed. But this is double the best drug that's used, more than double the best drug that's used to treat this disease. So I think that's a really important consideration. If we can crack this, we can sort that disease. And I guess this brings me to my next point. And we started to notice, like, we looked really at, well, why with the appropriate intervention? So it could be me, my dietitian, our psychologist, and we all kind of have in our clinic and our specialists, the same role in the NAFLD clinic. And that's really to establish a relationship with the child, obviously, and the family, to screen for complications, to make a diagnosis, but to really look at, well, what works for them. And we noticed a really high prevalence of anxiety, depression. And I think it is really important to recognize that, and I think it's the same with obesity, but children and young people with NAFLD and these are adult data, but it's kind of the same, that, you know, they have, you know, a notoriously kind of poor quality of life, and that's compared to, you know, PBC, which is primary biliary cirrhosis, which is an awful disease. So they're really running around the fatigue. So this is fatigue impact score. So they are as tired as these poor women. So women with NAFLD are as tired as these poor women with this crucifying disease, which keeps them up all night with itching. And you know, without necessarily any kind of you know, understanding of why that is. We know from again from the US and from our own studies that children with NAFLD have a worse quality of life than healthy controls, reporting fatigue in nearly 70%, sadness in 50%, irritability in 3/4, trouble concentrating, trouble sleeping. And, you know, part of that is absolutely the obesity, bullying, self-esteem, maybe eating is a coping mechanism. But what we know, you know, and you know, these are our own data, that depression and anxiety are really prevalent in our cohort. And we started looking at, well, you know, how does that impact on their response to treatment? And we know that comorbid depression really affects treatment outcomes. So even though we were piling in the, you know, the education first off, but also you know, the support, and, you know, how they were getting on with weight loss, with lifestyle change, etc. And it has a huge impact. And, you know, we started to say, well, actually, unless we can address that, there's no point really in banging on again, you know, about healthy lifestyle, etc. Because they just don't hear it. And their willingness to change is, you know, is what it's all about. And I don't have any magic formula for that. But what I do know, or what I've seen, is if you stick with it, if you keep up that therapeutic relationship with that family, the majority, in the end of the day, come through that. And, you know, you try and get the appropriate supports, and we know that, you know, obviously we're underfunded for that. But I think that therapeutic relationship is really undersold. And I think it's the one thing that kind of helps. So just, you know, to finish off then, I mean, I guess my general approach to NAFLD in children and young people is, you know, first of all, is this NAFLD? You know, then I kind of think, well, if it is NAFLD, and I'm happy that I've ruled out everything else, and how bad is the liver disease? I mean, should I be managing this patient, or should I be just charging them back to the GP? And then how should I manage this patient, and how should I follow them up and monitor progression? And, you know, I'm very practical in terms of, you know, again, it is very individual, and sometimes my dietitian will take them on more than I will, or the psychologist will be the person, and we'll all meet and discuss. And I think, you know, with COVID, I've seen that actually virtual clinics have a place, even though I can't do an ultrasound scan or a blood test. Maintaining that therapeutic relationship is doable. And I think a scan every year to 2 years, yes, for me, but actually more so that, you know, that the patient will see progress and get something out of all the hard work that they're putting in. So in summary then, and I'm sorry I'd tend to pontificate a little bit about this condition, and very happy to take questions, but I guess NAFLD in children, you know, it's not all about BMI, and I think it is a bit different from the disease in adults that we hear more about. Really important factors in influencing response is mental health. And you know, I'd advocate for a very individualized approach to both evaluating and managing children. And I guess because, you know, particularly in pediatric hepatology, we're in a more privileged position than in the adults, who are just, you know, having patient after patient coming at them. We do have the time to kind of sit back and think, well, if you've got a real risk of progressive disease, let's put the effort in now, and we potentially will save you a transplant. And I think in the future then, recognizing genetic, you know, the variability, the susceptibility, and other risk factors is the key to kind of targeting treatment. So thank you very much. I don't think I can see my chat function very well on this page. Or maybe I'll just try and see what's going on here. But I wonder, does anybody have any questions, or, you know, anything, any comments? This is probably a condition that you guys are seeing more and more.
you were just touching on at the end of the talk, and I thought it was really interesting about how these sort of classic pharmaceutical therapeutics are kind of not seemingly as effective as other measures that are going to be focusing on weight loss. And I just wondered, what does the care setup look like for a child with NAFLD in terms of the MDT? So which you mentioned a bit, but I wonder if you could expand a bit more about which members of the team would be involved, and how does that all work?
So we kind of took our inspiration from one of the projects in the Evelina, which is kind of around obesity and the importance of kind of family. There's a family therapist involved, and a really good MDT. Now, we couldn't afford any of that, but what we tried to put together was people who were interested. So myself, really interested dietitian, clinical nurse specialist, and a psychologist who we didn't have we wouldn't psychologist for whole liver disease, but who could provide a backup. And I think in the NAFLD clinic, I've been caught with kind of suicidal ideation more than in any other clinic I've ever done. So I think it is really important to have somebody who knows the pathways from that perspective involved. So we would meet every kind of 2 weeks, discuss patients, and then kind of take the lead on various patients who may need, and that's the whole point of an individualized approach. And we were a little bit bubble wrapped with that, and because it was kind of a pilot study. But as I say, I think myself and Helen Mortimer, the dietitian in King's, who really is interested in this, would kind of really see a patient kind of in tandem. So I may not need to spend much time with them, but Helen would spend much more time. I mean, I think at the beginning it is much more clinician centered, because I think it's really important to emphasize that we can't be missing Wilson's or autoimmune or any other liver condition. And then once we're happy with the diagnosis, we all know them, but I think psychology, in my ideal world, psychology, dietitian, and clinical nurse specialist is the way to go. But it's not terribly practical.
Thank you. We've got a couple of questions in the chats here. So there's Geraldine says, thank you. Is there a role for bariatric surgery or fitness training in tackling NAFLD?
That's a great question. So yes, I think to both. So the bariatric surgery question is really interesting. So we know, so King's actually has a pediatric bariatric surgery program, which is not particularly focused on our service, but we've had a couple of kids go through, and we know actually, just as in type 2 diabetes, that bypass, which isn't really done in pediatrics, really again transforms the disease. So my practical approach to that is, and these are mostly kids at 16, 17, so you're allowed to use absolute BMIs, BMI 40. So I think if you have BMI of 40, it is really, really hard to get down from that without bariatric surgery. And I think maybe one has been successful. But with bariatric surgery, you need to be, as you know, totally committed to it, because there are ways to cheat. So it's a long process, and you need to show your commitment. And that, with the whole prevalence of anxiety, depression, is not always achievable. So I think in summary, I think in kids and young people with BMIs up there at the 40 range, and or 35 with type 2 diabetes, etc., absolutely the way to go. And the data from the States would absolutely support that. Fitness training is a really interesting concept, because there's a lot more interest now in kind of sarcopenia and NAFLD and that unhealthy kind of metabolic risk. There's not a huge amount out there to show success or not, but actually I should have mentioned, in my ideal world, a physio would absolutely be part of the multidisciplinary approach, but I've not had the opportunity actually to look at that in any detail myself. But I think it's definitely got legs.
Brilliant, thank you. And another question here from Helena, which is, thank you for the great talk. Sorry if I missed it. Can IBD develop secondary to NAFLD, or can NAFLD develop in the context of IBD? How can we know what patients are at a higher risk?
So that's another really good question. So there's some well, there's a decent amount now actually looking at, again, visceral adiposity in IBD. The latest stuff that I've read isn't particularly NAFLD, but if you look at, kind of metabolically unhealthy children with IBD, you've got malnutrition, I guess, but not, they can still be obese, and their nutrition can be inadequate, and you've got that inflammatory response, so contributing to kind of visceral adiposity, or chicken and egg, I don't know which comes first, and then you've got the treatment, so steroids particularly. And I don't know if you've seen, but particularly when we get kids feeling better, so those, say, if we start them on infliximab, they tend to put on weight really rapidly. And again, if there's a genetic susceptibility there, and they're putting on kind of bad weight because they're feeling better, and again, they're still a little bit metabolically unhealthy because they're not completely treated, transmurally yet, they can absolutely develop some fat in the liver. Now, to be honest with you, I mean, I've not really, maybe a handful of kids in that category, and they've not particularly been the very fibrotic ones, but obviously you've got autoimmune liver disease to consider as well. But it's a very fair point, and I think it's something that we're seeing, particularly with kids with UC now, more and more, as we're getting better and more aggressive at treating them. Likewise in CF, actually. So steatosis in CF, it's always been described, but nobody really understood it. And now I'm worried that we've got this cohort of really good nutrition in CF that may be overdoing it a little bit, and we've got the balance a little bit wrong. And I don't know if that fatty liver is NAFLD or if it's something else.
Fantastic, thank you. I don't think there's any further questions at the moment.